Alright, now that we've officially covered the presentation and workup of AFib and Aflutter, it's time to do something about it. First, we'll focus on treating a patient presenting with new onset AFib or Aflutter. Then we'll wrap up the sketch with a discussion of long term management. Yup, it's the winter formal at Narrow Pines Retirement Facility, and the hearts are a fluttering. That's not your pacemaker out of whack, my friend. Love is in the air. Get ready for a night of partying, prunes, and Perry Como. In case you need a little refresher, here's what we've covered so far. AFib and Aflutter most commonly present as narrow complex tachycardia, so we've put an elevated heart clock on the wall to represent tachycardia. I say narrow complex because these two supraventricular tachycardias originate in the atria and send impulses through the AV node before hitting the conduction system of the ventricles, thus producing narrow QRS complexes. Now, we will see SVTs, such as AFib and Aflutter, create wide complexes as well. But this is only if they hit an aberrant conduction pathway on their way to the ventricles, or an accessory pathway causing ventricular preexcitation. In either case, slower depolarization causes wide complexes. Head on over to the police station for all the details. AFib, as always, is symbolized by an irregular static tracing on a TV screen. In the setting of AFib, the atrium can generate over 350 electrical signals per minute, but only some of these signals are transmitted down the AV node, leading to an irregular rhythm with different RR intervals and no obvious pattern. Instead of P waves, expect to see wavy erratic fibrillatory waves between the transmitted QRS complexes. At the bottom of this sketch, we've also brought in our recurring symbol for atrial flutter, an erratically jumping wiener dog with her ears fluttering behind her. Aflutter involves a mini re-entrant circuit in the atria, causing them to fire around 300 beats per minute. On the ECG, you'll see flutter waves instead of P waves between each QRS. They're generally described as forming a sawtooth pattern. The AV node blocks some of these impulses, and others get filtered through, forming narrow QRS complexes as the ventricles get activated, which is why this fluttering wiener dog is performing lots of little hops, but every once in a while a big jump as she depolarizes the ventricle, if you will. Usually, only one out of every two signals are transmitted through the AV node down to the ventricle, resulting in a QRS complex. This is called atrial flutter with a 2-to-1 block, and results in a ventricular rate of about 150 beats per minute. Other ratios can occur as well. If there's no variability to the AV block, a regular tachycardia develops. But if the degree of that block changes from second to second, which is common as well, it can result in different RR intervals and an irregular rhythm. Alright, recap over. Let's get this party started. See new guy over here? He represents a patient who presents with new onset AFib or Aflutter. First things first, are they stable or unstable? Although most patients will be stable. I mean, just look at Selma over here. We've made her trip over a heart failure balloon because patients who present with unstable AFib or Aflutter probably have underlying cardiac dysfunction. Their hearts just can't keep up with the hemodynamics of the new onset arrhythmia and loss of atrial kick. Immediately assess for hypotension, altered mental status from poor perfusion, signs and symptoms of acute decompensated heart failure, or rate-related cardiac ischemia. Due to the critical nature and need to reverse these issues, we need to restore sinus rhythm as quickly as possible. The fastest way is with electricity. In the unstable patient, immediate synchronized DC cardioversion is indicated regardless of the duration of symptoms, which is why the new guy is wearing synchronized heart watches and holding a pair of high-voltage party sparklers. This is a recurring theme throughout this chapter, if you haven't noticed. For stable patients with AFib or Aflutter and tachycardia, the first step is rate control. So next to this lady stabilizing herself as she climbs onto the stage, we've drawn in a rate-controlling metronome. By rate control, we mean slowing the ventricular rate. Though the patient will usually remain in AFib or Aflutter, we're merely trying to optimize hemodynamics since the patient's symptoms are usually related to the increased ventricular rate. Rate control can be accomplished with medications that slow conduction through the AV node. At Sketchy, the AV node is represented by a note in the middle of a heart, controlling the conduction to the ventricles. And if you take a look at the light above the stage, you'll notice that conduction is getting interrupted. Medications that affect AV node conduction include beta blockers and the non-dihydropyridine calcium channel blockers, symbolized, as always, by a muted beta bugle as well as a calcium ice cream machine. Notice that the flavors of the day are non dairy, very vanilla, and delicious dark chocolate, representing verapamil and diltiazem specifically. We generally titrate these medications with a goal heart rate of less than 110 beats per minute at rest or 85 if symptomatic. These are usually started as IV doses or infusions. In patients with depressed systolic function at baseline, symbolized by this loose, depressed looking heart accordion, digoxin may be a good choice. Hence the foxglove flowers in the accordionist's pocket. Digoxin will not be a first line in most patients, however, as it has a slower onset of action and increased problems with toxicity. Word of caution: patients in AFib with pre-excitation should not be given AV nodal blockers. You remember pre-excitation, right? It was first introduced in our narrow complex DDX video. Those two white wolves represent an impulse from the atria heading down to the ventricles through the AV node and an accessory pathway at the same time. In these patients, the ventricles get activated by the accessory pathway a bit earlier than normal, pre-excited with every beat, in other words. Look for the classic Wolff-Parkinson-White findings on the ECG, including a widened QRS with delta wave and a short PR interval. We've incorporated those Wolff-Parkinson-White wolves on the pennant flag in the back of the room. Wolff-Parkinson-White High School, class of 1958, baby. In these patients with pre-excitation due to anterograde conduction across an accessory pathway, adding an AV nodal blocker, such as a beta blocker or calcium channel blocker, kinda diverts all the impulses down the accessory pathway, which can result in a significant increase in the ventricular rate, leading to hemodynamic instability and VFib. So, above the door, we've written "do not block." Don't be that guy. Instead, we go straight to rhythm control. Speaking of, now that the patient has been appropriately rate controlled, we need to decide whether or not to pursue rhythm control. In other words, do we need to go one step further and convert our patient to sinus rhythm? Conversion to sinus rhythm will be represented by this reset kinda arrow symbol on the dance floor. Think of it as resetting the heart back to normal. Attempt to restore sinus in most patients with new onset AFib, even if asymptomatic, because the best chance of successful restoration and maintenance of sinus rhythm is at initial diagnosis. The synchronized watches, along with those high voltage party sparklers, should remind you of synchronized electrical cardioversion, the preferred method for restoring sinus rhythm in new onset AFib. Antiarrhythmic drugs, such as flecainide or propafenone, are sometimes given along with electric cardioversion to increase the chance of success. So-called pharmacologic cardioversion, in which meds are given alone without electric cardioversion, is rarely pursued for new onset AFib and Aflutter. Reasons not to cardiovert in new onset AFib or Aflutter? How about Leonard over here? Completely asymptomatic and elderly with multiple comorbidities. You know he's elderly because of the grays. You can tell he's asymptomatic because of that spring in his step. And thirdly, you know he has underlying comorbidities because of that unraveling heart on his sweater. Perhaps he has underlying heart failure. Cardioversion requires anesthesia, and the risks associated with anesthesia and/or antiarrhythmic pharmacotherapy are not worth the potential benefit in these patients. Instead, these patients are continued on rate controlling medications. Now, before we jump straight into zapping your patient with new onset AFib, we need to assess the timeline. As we discussed in the previous sketch, AFib and Aflutter can lead to formation of a thrombus in the left atrium or left atrial appendage. Not only that, the cardioversion process temporarily increases the thromboembolic risk even further. If new onset AFib has been present for greater than 48 hours, or it's unclear how long the arrhythmia has been present, the risk of atrial clot formation is high enough to warrant at least 3 weeks of therapeutic anticoagulation prior to cardioversion. Some experts say 4 weeks. So, in this scene, the guy next to the 48 max capacity sign is being halted, not allowed on the cardioversion dance floor. And above, the old-timey commercial advertises 3 to 4 weeks of anti-clog anticoagulation. Now, you don't have to wait 3 to 4 weeks prior to cardioversion if a transesophageal echocardiogram is performed, documenting the absence of an atrial clot. Move on to the cardioversion dance floor, my friend. 2 important points here. First of all, that's transesophageal echo, not transthoracic, which is a much less sensitive imaging technique. Secondly, if your patient has likely had AFib for over 48 hours, start anticoagulation right away. Do not delay anticoagulation to obtain a transesophageal echo. Once the patient is on anticoagulation and the results of the echo come back, you can decide to move on to cardioversion from there. Here's the good news. If a patient has been in AFib for less than 48 hours, it's unlikely that there's been enough time for an atrial clot to form, and cardioversion can be done without delay. Party time! Now, that doesn't mean you can forget about anticoagulation, though. Cardioversion can cause atrial dysfunction, also known as atrial stunning. So, many providers start these patients on anticoagulation before the procedure. See this stunned lady here? Impairment of atrial function can last for weeks. Not only that, we've added a fibrillating trace on her dress to remind you that recurrence of AFib or flutter within the first month is common. So, if cardioversion is successful, all patients who are started on anticoagulants before or during the procedure will continue therapy for at least 4 weeks. Alright, now let's talk long term. If this is the patient's first episode and cardioversion is successful, he or she does not need to be on antiarrhythmic medications at home, even if they received medications as a part of cardioversion. However, most patients with paroxysmal AFib will have recurrent episodes, and many will eventually progress to persistent AFib. For patients with persistent AFib or frequent paroxysmal AFib, long term therapy is needed. So, we've brought in our chronic grandfather clock symbol next to the newspaper stand displaying the words recurrent and persistent. There are two main strategies we can pursue for these patients: rate control or rhythm control. These will be illustrated on each side of the piano, next to the rate controlling metronome on the left and the rhythm inducing songbook on the right. Either method will help treat symptoms and prevent tachycardia induced cardiomyopathy from developing in the long term. Be classy, not tacky. You're better than that. But here's the thing: rate and rhythm control are associated with a similar rate of mortality and stroke, represented here by the equal sign hat covered in thromboembolic bird poops. That's right. You'd think that rhythm control is better than rate control, since rate control meds merely control the ventricular rate, while the irregular rhythm persists, which, theoretically, can lead to blood stasis and clot formation. But patients on only rhythm control also remain at risk of stroke even if they appear to be in normal sinus rhythm. Turns out that there may be undetected and often asymptomatic periods of atrial fibrillation. All in all, stroke risk is decreased with both methods, but not zero. Rate control is preferred over rhythm control for many patients because of a lower rate of side effects. This is especially important in elderly patients since they're typically more sensitive to the effects of drugs, and their arrhythmia, which is usually long standing, is less likely to convert to sinus anyways. Rate control is generally preferred in asymptomatic patients as well, which is why, over on the rate metronome side of the piano, we've drawn in a hip granny who's smiling and symptom free. Remember that the rate control meds are your AV nodal blockers, which include beta blockers, calcium channel blockers, and digoxin, all of which were highlighted around the band members up on stage. There are, on the other hand, a few situations in which rhythm control is preferred. This includes in patients who are younger or who haven't had the arrhythmia for as long. So, over on the rhythm side of the piano, we've drawn in a few younger visitors. These patients are more likely to convert and stay in sinus rhythm. Other patients with chronic AFib or aflutter who may benefit from rhythm control include those who have failed rate control. And by that I mean patients who continue to have tachycardia or continue to exhibit symptoms despite adequate rate control. This is represented by the broken metronome on the floor there, as well as the symptomatic grandma overcome with nostalgia, I guess. She'll be fine. Common drugs used to convert and maintain sinus rhythm include class 1 antiarrhythmics, such as propafenone and flecainide, symbolized by the purple phone and flakes. Class 3 agents include amiodarone, sotalol, and dofetilide, symbolized by the amigo hat, soda bottle, and the I Do Till I Die wedding album. Oh, the memories. Sometimes these meds are given in addition to electrical cardioversion. Let's add another bottle of anti-clog solution next to the songbook as a little reminder that any patient who has chronic AFib and is being converted to sinus rhythm, either pharmacologically or electrically, must first be anticoagulated for at least 3 weeks prior to cardioversion. That is, of course, unless a transesophageal echo demonstrates the absence of an atrial clot. Additionally, just like we highlighted out on the dance floor, anticoagulation is often started at the start of cardioversion and for at least 4 weeks after. If your patient doesn't require long term anticoagulation, that's all they'll need. One of the big drawbacks to rhythm control versus rate control is related to drug side effects. This includes a pro-arrhythmic effect. That's right, these drugs used to maintain sinus rhythm actually have the potential to precipitate arrhythmias. What? Kinda counterintuitive, right? Patients on these meds need to immediately report symptoms such as dizziness, syncope, or dyspnea, and be aware of the risk of potentially fatal arrhythmias such as VTAC, torsades, or VFib. Patients on Class 1A or Class 3 drugs must also avoid other drugs that prolong the QT interval. Renal function should also be assessed, as renal insufficiency can allow drug concentrations to increase, enhancing the proarrhythmic effects. And finally, it's extremely important to assess for the presence of underlying heart disease, as emphasized by this floppy failing heart balloon. Flecainide and propafenone, for example, are contraindicated in patients with coronary artery disease. Sotalol, propafenone, dronedarone, and flecainide are contraindicated in patients with heart failure. And in patients with left ventricular hypertrophy, sotalol, flecainide, and propafenone are associated with increased risk of arrhythmia. See? It gets complicated. Rhythm control with radiofrequency catheter ablation is an alternative to antiarrhythmic drugs. Hence the ablated and broken radio over here in the corner. Most frequently, this is performed in patients who have failed or are intolerant to antiarrhythmic drugs, though it can also be performed without a trial of drug therapy. Ablation targets the tissue responsible for initiating the abnormal rhythm, which, in the case of AFib, is usually the myocardium surrounding the pulmonary veins. Now, we've already discussed the anticoagulation needed when first converting your patient to sinus rhythm, but some patients will also need long term anticoagulation. The need for anticoagulation must be assessed in every patient regardless of whether rate or rhythm controlled. Remember that the risk of embolic events and mortality are comparable between these two treatment groups. However, anticoagulation itself is not benign and the risk of bleeding should be taken into account. Generally, patients with features consistent with a high risk of stroke and lower risk of bleeding should be anticoagulated, and people with a higher risk of bleeding or absolute contraindications to anticoagulation or lower risk of stroke should not be anticoagulated. Simple ish. Base the need for long term anticoagulation on risk of embolic stroke using the CHADS 2 VASC scoring system. This is essentially a risk factor based scoring system with a maximum score of 9 and increasing risk of stroke with an increasing number. A score of 0 is considered low risk, and anticoagulation is generally not recommended. A score greater or equal to 2 is high risk, and anticoagulation is generally recommended. A score of 1, however, is intermediate, and the decision for anticoagulation has to be made on a case by case basis. To emphasize a score greater than 1 requiring definite anticoagulation therapy, we've incorporated a greater than 1 into the vacuum cleaner. And for all the components of the score, just think of CHADS VAX. Check out the text on the screen for all the details. Alright, once we determine the need for long term anticoagulation based on the risk of bleeding complications and risk of embolic stroke thanks to the CHADS 2 VASC score, what are our options? The oldest and cheapest option here is warfarin. Warfarin is an oral medication that inhibits vitamin K dependent coagulation protein synthesis in the liver. However, there are a few downsides to warfarin. Warfarin requires regular monitoring to keep the INR in the therapeutic range with the goal INR of 2 to 3 in AFib and Aflutter. Lots of other drugs and even a patient's diet, like how much vitamin K they consume, can affect its efficacy. Warfarin requires several days to reach full anticoagulant effect. Nevertheless, for most patients with AFib, warfarin can be started alone without need to bridge with heparin because of the overall low risk of a thromboembolic event. In patients who are higher risk of thromboembolism, for example, if they have a history of thromboembolism or a known atrial thrombus, bridging with heparin is needed. Other options for long term anticoagulation include the newer direct thrombin inhibitors or factor Xa inhibitors. These are commonly grouped together as NOACs or novel oral anticoagulants. The upside to these medications is that they act much quicker and also do not require bridging therapy. They're also independent of vitamin K and do not require regular monitoring, making things more convenient for your patients. The downsides include the cost, as they are way more expensive than warfarin, and they're not approved for patients with chronic kidney disease. Alright, though most of the points we've covered in this sketch apply to both AFib and Aflutter, I just want to wrap up here with a few points about atrial flutter specifically. In the long term, Aflutter is typically managed with rhythm control because, unlike an AFib, patients are usually still symptomatic when rate controlled. So we've made sure to include this Aflutter dog on the rhythm control side of the piano. Point number 2. Radiofrequency catheter ablation is usually pursued because it's highly effective and has a low rate of complications. Ablation of atrial flutter usually targets the cavo-tricuspid isthmus of the tricuspid annulus. Antiarrhythmic drugs are used less frequently. All right, let's sum up this geriatric dance party, shall we? We've covered two types of patients: those with new onset AFib or aflutter, and those with recurrent paroxysmal or persistent disease who may need long term therapy. Let's start with new onset. Unstable? Shock 'em. Are they stable? Well, decide whether they need rate control. Most patients do. This will slow the ventricular rate and improve symptoms. Use an AV nodal blocker. Do not give AV nodal blockers to patients with pre-excitation syndrome, lest you want to divert all the atrial impulses down the accessory pathway, leading to a significant increase in the ventricular rate, hemodynamic instability, and VFib. For most patients with new onset AFib, the next step is cardioversion to restore sinus rhythm. This is typically achieved with synchronized electrical cardioversion. Antiarrhythmic drugs may also be added. Pharmacological cardioversion, i.e., cardioversion with drugs alone, is not typically done. If your patient has had AFib for less than 24 hours, cardiovert immediately. If your patient has had AFib for over 48 hours, he or she will need at least 3 weeks of anticoagulation before cardioversion to lower the risk of thromboembolism from an atrial clot, which may or may not actually be hiding in there. After you've started them on anticoagulation, you can check for a clot with a transesophageal echo. No clot? Awesome. Now you don't have to wait the full 3 to 4 weeks. Just go straight to cardioversion. A few side notes about cardioverting a patient with new onset AFib. Asymptomatic elderly patients with comorbidities do not typically get cardioverted because of the risks associated with anesthesia and antiarrhythmics. Just rate control that dude. Anticoagulation is typically started right before cardioversion and continued for 4 weeks afterwards. This is to prevent thromboembolic events caused by atrial stunning and or recurrent AFib in the month following the procedure. How about the not new onset of AFib? We are talking recurrent paroxysmal or persistent. Well, the big decision here is between rate control or rhythm control. Both decrease symptoms, decrease risk of recurrence, and decrease the long-term risk of tachycardia-related cardiomyopathy. Both methods reduce the risk of thromboembolic events, though the risk isn't zero no matter what strategy you use. Rate control is often preferred because of the lower rate of side effects, especially important in asymptomatic or elderly patients. Rhythm control is typically pursued in younger patients who haven't had the arrhythmia for as long. Rhythm control may also be appropriate for patients who continue to have tachycardia or symptoms on rate control. Aflutter, specifically, is typically managed with rhythm control rather than rate control. One of the big drawbacks to rhythm control is the drug side effects. They can precipitate potentially fatal arrhythmias, and this risk may be increased in the setting of underlying heart disease. So, assess your patient for coronary artery disease, heart failure, or ventricular hypertrophy. Some antiarrhythmic meds might be contraindicated in these settings. An alternative to antiarrhythmic meds is radiofrequency catheter ablation. In Aflutter specifically, this is often the treatment of choice. Does your patient need chronic anticoagulation? Well, if they have a high risk of thromboembolic events based on the CHADS2 VASC, combined with an acceptably low risk of bleeding, it's time to anticoagulate. Go with warfarin or a NOAC. Warfarin must be monitored. Shoot for an INR of 2 or 3. For both classes of meds, bridging is not usually necessary, though bridging with heparin may be pursued in patients starting warfarin who have an exceptionally high risk of thromboembolism, like those with a history of thromboembolism or known thrombus. Aw, yeah, this is my jam! Well, that's it for our series on narrow complex tachycardia. Next up, wide complex. Now, if you'll excuse me, that dance floor isn't gonna Lindy Hop itself.